Okay, folks, so it's past, so we've got report out as usual, Friday lunchtime. Thanks very much for joining. I'm delighted to welcome Chris. And are you on your own today, Chris?
I am, Julian, yes.
Oh, well, that's impressive. Really good to hear from you, Chris, on the work you've been doing on rapid discharge home and the respect process, and that's certainly a process that I know you've taken me through before, which is really important in terms of how we work and the engagement of all of the ward teams particularly. So I'm going to hand over to you and look forward to hearing your report out. So Chris, over to you.
Thanks very much, Julian. Yes, as Julian mentioned, my name is Chris. I am a lifeline nurse in the specialist palliative community. I've been working on a project as part of a secondment with the KPO team for the last year or so, and that's gone incredibly quickly. But we've been looking at the fast track discharge home for end of life care. So this is a group of patients who have reached the limit of their treatment options whilst in hospital. A decision has been made that they are approaching end of life, and we are looking at fast track discharging them home. So by very definition, patients that fall, could I have the next slide please, Jimmy? I'm not sure if I'm advancing slides, thank you. So we know from national data, and this is the Voices survey, which is a survey of bereaved relatives which is run annually, that people don't choose to die in hospital. We look at around only 2% of patients would actually choose to be in hospital for their end of life care. But that roughly works out that around 50% of people that die in hospital. So there's a little bit of a disparity there with around advanced planning, etc. So we know that generally people don't want to be here for their end of life care. And we can then distill that down to the fact that if we are going home for end of life care, it's highly unlikely that we would then want to be readmitted in a crisis. And crises do occur. There might be several calls to ambulance or community staff for support in the home, and rightly so, because it's quite a frightening place to be for carers and relatives. So the initial data that told us to look at this problem or a potential problem was highlighted in the mandatory medical audit, which had a palliative care element to it in 2019, which actually showed that 2 patients who had gone home under this system had actually been readmitted based on a crisis that had been at home and brought back into hospital. So we know that it's an issue. We didn't really know how big an issue it was, and we didn't really know how to crack that nut because respect is a relatively new process in the trust. It's probably been around 3 or more years. We're really starting as clinicians to get our heads around the use of respect forms as an in-hospital treatment escalation plan. So do we ward level care, or is there an escalation up to ICU or level 2 care? But what we don't tend to do is use the much more richer elements of respect, and we often don't think about outside the boundaries of the hospital, so we don't necessarily think about the impact of what we record on the respect form, what that might mean later on for the patient and their families. So could I have the next slide please, Jimmy? So this is some data that I've got. The data does show, unfortunately I'm struggling to keep up with collecting the data because it's quite a heavy involved process to extract the information I need for each patient. But the top graph shows on a weekly basis the number of fast track patients in the hospital waiting to go home for end of life care, and the red line shows us those patients who had useful information recorded on their respect forms. The grey line shows that somebody might have had something on their respect form, but it wasn't useful information. It might have been a comma or a space, which then still populates the form itself. So the blue line and the red line are the important ones to think about. And you can see really early on, I thought I was getting somewhere, but then my margins widened again. And unfortunately, that only goes to June because I'm struggling to actually keep up with collecting the data. And I hope that the last few months are showing a closing of that gap. And then it's actually broken down into CSU level, and we do have it in speciality level as well, but didn't think it was appropriate to show you that, where we have the running total of the fast track patients, a number of the patients that have had their readmission plan indicated, and what percentage of that, what proportion of patients that is. You may have picked up on some of those numbers already. The interesting one for me to just draw your attention to for a reference to a bit later on is AMS, which I've put at the top, which runs at 75%, and we'll talk about that next. If I could have the next slide, please, Jimmy. So these are some of the things that I, along with lots and lots of colleagues throughout the trust, have done. It's kind of been my project and me coordinating it, but we've tried different interventions in different areas. So with reference to AMS being at 75%, this is something called Pete's Plan, which is led by a discharge facilitator called Angela Colmer, who had personal experience of her husband being fast track discharged home, and it was a very good discharge. Everything went well, and her husband Pete died at home peacefully in his bed with his family around him. And Angela, upon her return to work, has made it a real personal mission. It started as a personal mission. It's evolved now into actually a fully substantive post. She is now permanently in post, and amongst the discharge facilitators in AMS CSU, she is the focal pivotal point for fast track discharges. So Angela gets involved with every fast track discharge and actually oversees that and acts as a single point of contact for the professionals and the families that are involved. The feedback for that has been absolutely fantastic, and all that will go into a final report. And it's something that we may want to think about a scale up later on, because it seems to be the most effective intervention. Some of the other things that we've done, we spoke to YAS staff and we asked them how it feels to be in the patient's home with an incomplete respect form. And some really emotive responses from them, telling us about their frustrations, and not only that, but about how good it is for them in the home to have a well completed respect form. We've done some work with some advanced clinical practitioners who feel ideally placed to be involved in these discharges. They are confident, highly qualified healthcare professionals that not only get involved in the process, but also will role model these good conversations for our more junior medical staff and nursing staff, etc. We've done some education sessions with the oncology doctors. Quite difficult to get a big group of them at any one time, but that's work that is ongoing. We've had an advanced care planning project running up in ESM with a Dr. Emily Holdsworth, who's been using something called clinical frailty scores and looking at that to trigger an advanced care plan discussion. We're working with the Leeds team, the Leeds Integrated Discharge Service, so that's early in that intervention, but again we've had an education session and we are starting to ask them to prompt their medical colleagues to update these forms. We've updated the respect policy because it actually wasn't in the policy when we first started, and now respect education run by Becky Cannon and her team incorporates the readmission plan. Same for discharge training sessions. We've had a few medical students who've undertaken a survey of junior doctors to look at the reasons why these conversations can be challenging or don't always happen. And the report's not complete yet, but it does highlight how it's often senior doctors making these decisions and then junior doctors following through on the actions from the ward round and things like that, and they often don't feel equipped enough to open those conversations, or indeed have enough information to really answer any questions from patients and relatives should they come up. So there's some work to do there. We've built something called a Padlet, which is a fabulous internet-based resource which has lots of videos and multimedia and PowerPoints and things on, which we're going to use as an educational tool. And then one of the things that I thought was really important was to just celebrate some small successes. So whenever I have found a well-completed respect form, I've taken an exam, I've used it as an example, so I've got lots of good examples of what people can write on the forms, and I've actually contacted the consultant and the junior doctor or the other healthcare professional involved just to say, well done, this is really, really good, and just thank you for just providing such rich information, really. Could I have the next slide, please, Jimmy? So it is early stages yet. It's sunk in quite a while ago to me that this is part of a bigger culture around advanced care planning, putting patients at the centre of their decisions, giving them much more power to tell us how they would like their care. And again, that needs just that's a constant change as we move towards that, you know, the power of the patient, etc. So we need to just keep going with it. Definitely AMS, Pete's plan is absolutely fantastic. I do think that it will go up and above 75% when I capture the data for the last couple of weeks, because that's really got going over the last couple of months, really. I now know where my areas of greatest concern are, so I didn't know that at the beginning, so now I have data, I can actually start targeting certain areas and where there's larger numbers. Really pleased that we've got respect training and discharge training incorporated now, because people are actually starting to think about it a little bit more. And the next steps really immediately, I'm talking to the Discharge Collaborative in the next week or two, and report out today was one of those next steps. And then just to carry on with the work that we've done, really targeting those areas where there is a greater disparity. Could I have the next slide, please, Jimmy? So I think it's hard for me to say what went well really. I need my numbers greater just yet. I think we've made a good start, but I don't think we've really got there yet, certainly in areas other than ESM. But it has been received really well. Everyone kind of agrees how important that information is, and it's sometimes just about turning that light bulb on for people. And just giving them the understanding of the impact of a well-respected, a well-completed respect form. And I would just say it is beyond the scope of an individual, so I need lots of buy-in from other people, which I have received and have lots of support from loads of great teams and loads of great people across the trust, but there is still more steps to take. And last slide, please, Jimmy, if you would. So I suppose a more structured approach I put down there around what would I do differently. Hard to get that structure from the outset, really, because there is so many people involved in this process, and it can happen at any time for a patient in their journey. So there isn't really a way to clearly cohort patients to a degree, other than they are given fast track status. But then it's quite a bit of the clock is ticking at that point, so it's very hard to know exactly when this should be done. And there is a lot more talking to do, a lot more education. There's always going to be new staff coming through, but as we refine our offer of education, I think it hopefully just gets clearer and more concise, the message. And I suspect it's been run large through most report outs recently is the COVID restrictions, so really difficult to just be in the clinical area, be working alongside people and arranging meetings, etc. So hopefully as things get better, that will those opportunities will arise. So that's my report out. I am more than happy to take any questions or thanks, Jimmy.
Fantastic, Chris. Thank you so much. That's great. loads in there. Really good to see how you're using that sort of lived experience and the kind of the feedback and the insight that you've gained and putting that into practice. And I guess really this, you know, COVID's probably brought this into even sharper relief, hasn't it? So let's get into Q&A. So who'd like to kick off? Phil.
Thanks, Julian. Thanks, Chris, for that. Really great conversation. One of the things I remember from previous sort of conversations with the team is the timing of those conversations, and sometimes when we've got people in with us as patients, whether that's the right time to be having that conversation with them, and whether there are other opportunities across the system. I don't know what thoughts you've had about some of the conversations that we also need perhaps help and support from our colleagues outside hospital.
Yeah, and I think that's correct, Phil. And I think we are relatively new with respect implementation in the community, aren't we? So they're building their capacity and capability. And I think I would admit that mine is a little bit niche. It isn't going to be for everybody. It isn't going to happen to everybody. But I think because they truly understand the impact of a respect form that's completed improperly in the trust can then have out in community, they see the end result of that. And again, things like discussions around preferred place of death and preferred place of care, as the concept just sort of grows in the community and more people are involved, I think more people will be more comfortable to have those conversations. And I think certainly about the timing, certainly on admission, things like a treatment escalation plan are pertinent right there and then, and we get those nailed. It's really when we make that fast track decision that we've reached the ceiling of care and it's time to go home. That's for me when we're going to prompt that conversation, and it is quite a challenge to bring that in a little bit earlier, isn't it? Because often we know that patients can be quite reluctant themselves to enter into those discussions because there's that maintaining positivity, there's that if I think about this then I'm going to give up, or so yes, it's very nuanced around when that conversation happens, and I think there's no quick fix for that, is that there's a growing confidence maybe to have those conversations, but we're not there yet, I think.
Thank you. Thanks, Chris.
Thank you, Phil. Jenny?
Wow, Chris, that was a really important report out. What an important topic. And I can't remember, so I can remember when we first started talking about the implementation of respect. But I can't remember whether this is this an initiative new to Leeds, or does it exist anywhere else? I'm just, because my head went where Phil went, which was, you know, is there learning and the help from primary care was where my head went. But is this new across the NHS, or and I guess what I'm asking is are there exemplars where we can learn from?
Yeah, I think that we should be one of the exemplars, Jenny, to be honest, because it was quite disappointing in that it is a national issue, so it's part of the respect process is a national process. And I was really disappointed in that the National Respect team actually launched some short vignettes, some short videos around use of respect forms, and it had one about readmission plans and how important they were. But the video just showed it was all positive. It was, oh, Mrs. Johnson had her form completed and she got home and everything was perfect. It didn't go, Mrs. Johnson didn't have her form completed. And so I think I haven't found many other trusts that are working on this particularly. But I will admit that I've only really looked within palliative care circles rather than the wider, wider groups and networks. So it's certainly something that I can speak with Becky Cannon about and see whether she can engage with other Respect teams and see if there's any other good work going on there.
Well, and I'm clutching at straws, Chris, and I might well be way off piste. But I'm also thinking about those sort of charities that very specifically deal with this issue day in and day out as their area of expertise.
And I think that is a blessing and a curse to some degree, because I think that there is loads of other organisations helping support people in this manner, but it does then lend to a bit of confusion because there's so many different forms of advanced care plan. And one of the sort of early ideas that we're thinking about is actually, what do we promote in Leeds? What is it that is across the city? And there has been a large project across the region which has now produced a resource which is what's it called? I apologise, I can't remember the actual tool, but it's a region-wide thing, and I think that's the sort of tool we need to be tapping into. And there is a talk around trying to make all the different charities' versions of advanced care plans have at least some similarity across the board, and place of death is one of those elements. So I think we are collaborating with other organisations. There has been a group based at Gemma's and work gone on across the region, but again, that only captures those people that are involved, and it's those that are generally day to day, and Respect is just a small part of their work that we need to raise that awareness with as well, I think.
Well done. I mean, you've said it yourself, haven't you? There's a massive cultural element to this, and therefore we know that culture, that's going to slow up what you're trying to work on. So phenomenal work. Well done. Really, really good.
Thank you.
Thanks very much, Jenny. Any other questions or comments from colleagues? Chris, can I ask you what the sort of response has been from, clinical colleagues you're working with on this across the organisation?
Really good, really positive, Julian. Those that have managed to get engaged, because I think, I've got to be very conscious of how people feel at the moment, and getting hold of people has been the biggest challenge. But when we have got hold of people, I've done quite a lot of work with Andy Viggers, and again, it's received really well. So it's more just that light bulb moment of, have you thought about the impact of that? There's actually one example that I use, Julian, which I wouldn't necessarily expect you to recall it, but it was a relative sent you a letter which enclosed a completely blank Respect form, and she said the care that my father received was exemplary. I've said thank you to the hospital. You cared for my father brilliantly. Yeah. But could you just take a look at this blank form and tell me if this is what he should have received? And it's more just turning that light switch on, I think, Julian. It's received really understood, but it's just something that people have never really particularly thought about. Yeah,
I remember that. Absolutely. Yeah.
And I think we've spent the last 18 months getting our heads around the replacement for the DNA CPR form and the treatment escalation plan. I think now it's just building on that good work and just developing the process.
Yeah, absolutely. I'll just check before I draw it to a close. Any questions or comments or observations from KPO colleagues on this? Sophie?
Hiya. Yeah, thanks, Chris, for your report out. It's so inspiring, but I know you've done linked in some of your Lean for Leaders work to this work in terms of spreading the story. And it's obvious that it's working, and the incremental improvements just keep going, I think is all I would say. You're doing a brilliant job, and proud that you're part of our team.
Great.
I'm proud to be part of that team.
That's nice. Thanks, Sophie. Okay, Chris, thanks very much. You can hear from the comments the support and interest and enthusiasm we've got around this, and great to see this work developing, progressing, and really making a difference. So keep it going and come back to us, won't you, with further updates, because there's obviously a lot of interest in how that's going, and I can see the applause ripples across the screen, which is always a nice way to finish. So thanks very much, and thank you everyone for attending. Please do join us at the next report out, Friday the 10th September, 12:30 again. See you then. Thank you everyone. Take care.